The next step in the organized interpretation of a 12-lead ECG is evaluation of the intervals. As you might recall from Chapter 1, intervals incorporate at least one wave and an adjacent segment. Segments never involve the wave at either end of the segment, and durations are just the wave itself. In this chapter, we are going to focus on both normal and abnormal presentations of the PR interval. The PR interval is measured from the first deflection of the P wave to the earliest deflection of the QRS in that same lead. In general, the longest value that one can see in any of the 12 leads is the one that is taken to be correct. You have to be careful, however. In some leads, the QRS can be obscure in its beginning portions. If you are suspicious that this has occurred, pick another lead to measure the PR interval. A normal PR interval is between 120 and 200 milliseconds. That is between 3 and 5 small boxes wide. In other words, from the beginning of the P wave to the beginning of the QRS should be at least 3 small boxes, but no more than 5 small boxes. Let's take just a moment to review what is actually happening in the heart mechanically when the PR interval is occurring. Remember, we can't see the sinus node discharging on a 12-lead ECG. What we see is a result of the sinus node firing. Once the sinus node fires, the signal escapes from the sinus node complex and causes depolarization of the atrial tissue. The earliest depolarization that we can see is the beginning of the P wave. As the electricity spreads through both the left and the right atria, the P wave progresses. Once that signal hits the AV node, there is an inherent slowing of the signal, the basic traffic cop inside the heart. That signal is trapped inside the AV node complex as it moves slowly through that tissue. The signal then hits the His-Purkinje system and ventricular depolarization begins. Therefore, the PR segment, the space between the P wave and the QRS, represents the time that the signal spends in the AV node and early His-Purkinje system. Let's take a look at this PR interval. If we look in almost any lead and measure from the beginning of the P wave to the beginning of the QRS, we can see that this PR interval is just under 160 milliseconds, slightly smaller than 4 small boxes across. That would put this PR interval at approximately 150 milliseconds, well within the normal values of 120 to 200 milliseconds. This is normal sinus rhythm with a normal PR interval. Now that you have an understanding of a normal PR interval, let's talk about some of the abnormalities that we might find in the duration. The first is when the PR interval is too short, in other words, less than 120 milliseconds, or less than 3 small boxes in length. It is important to make sure that the PR interval you are evaluating is consistent across all of the complexes. If, as you look across the 12-lead, each PR interval is shorter than 120 milliseconds, then there are only 3 potential explanations for this phenomenon. In this 12-lead, we see the first example of a short PR interval. As you look across all 12 leads, you get the general impression that the PR segment, or the flat space between the end of the P wave and the beginning of the QRS, is abnormally short or even absent in most of the complexes. The PR interval, when measured directly, is at its longest 110 milliseconds, but in some of these leads is as short as 100 milliseconds. This is an example of the first of the causes of a short PR interval. This is called accelerated AV conduction. In the past, this particular ECG was thought to represent a clinical syndrome called Lawn-Ganong-Levine. This syndrome was thought to be caused by the presence of James fibers, which were extra electrical connections that were theorized to connect between the atrium and the His bundle directly, bypassing the AV node. In bypassing the AV node, they also bypassed its decremental conduction properties, therefore eliminating the PR segment from the tracing. We have since discovered that Lawn-Ganong-Levine is a highly questionable syndrome and is likely to exist only rarely, if ever at all. Almost all patients with a short PR interval, such as this, are secondary to either an underdeveloped and small AV node or extremely fast conduction in a normal AV node. The correct interpretation of this ECG is normal sinus rhythm with accelerated AV conduction. The second on the list of causes for a short PR interval is seen on this 12-lead ECG. As we look carefully, we can see that dual chamber pacing is occurring. There are pacing spikes in front of the P waves and pacing spikes in front of the beginning of the QRS complexes. The space between those is quite short, and there is no defined PR segment. The PR interval at its longest on this particular 12-lead is just under 120 milliseconds. An electronic pacemaker can be programmed such that the delay between the atrial pacing spike and the ventricular pacing spike is as short or as long as the programmer desires. There are many clinical reasons why we might program a pacemaker to have such a short PR interval, but there is nothing wrong or abnormal about the presence of the short PR interval in this particular 12-lead. The correct interpretation is dual chamber pacing. No further comment needs to be made about the short PR interval. The final cause of a short PR interval on a 12-lead ECG is seen in this tracing. The PR interval across all of these leads is well under 120 milliseconds, and again, the PR segment seems to be missing between the P wave and the QRS. What is different about this particular ECG as opposed to accelerated AV conduction is that the beginning of the QRS complex is sloped rather than vertical. This sloping is best seen in leads 1, 2, 3, AVL, and AVF. Leads 1 and AVL have an upsloping beginning portion of the QRS, whereas leads 2, 3, and AVF have a downgoing slope to the beginning of the QRS. This is abnormal. If we compare this to a normal QRS, as seen here, it is abnormal for the beginning of the QRS to have such a slow and gentle takeoff from the baseline. That is called a delta wave. This ECG is classic for WPW preexcitation, or a Wolff-Parkinson-White preexcitation. 1 out of every 1,000 people around the world is born with an extra connection between the atria and ventricles. Instead of just the AV node, these patients have both an AV node and an extra connection called a bundle of Kent accessory pathway. It is a separate electrical connection which allows conduction between the atria and the ventricles. Because this connection is separate from the AV node, and because the AV node is the only piece of electrical tissue in the heart which has decremental conduction properties, there is no PR segment in patients who have an accessory pathway that functions in the forward direction. The correct interpretation for this ECG is normal sinus rhythm with WPW preexcitation. Let's take just a few moments to review what we have learned so far about the PR interval. The PR interval begins at the beginning of the P wave and runs until the beginning of the QRS complex. It involves the P wave and the PR segment. It represents conduction through the atrium, through the AV node, and through the early parts of the His-Purkinje system. The normal value is between 3 and 5 small boxes wide, in other words, from 120 to 200 milliseconds in duration. There are 3 causes for a consistently short PR interval. These are accelerated AV conduction, which is manifested by a short PR interval with almost complete loss of the PR segment, but a normal beginning to the QRS complex in all 12 leads. The second cause is dual chamber pacing with a very short AV delay programmed into the device. And the third is WPW preexcitation. WPW is manifested by a very short PR interval with loss of the PR segment and a sloping beginning to the QRS complex. This sloping can occur both in the upward and downward directions. Let's now move on to the causes of a prolonged PR interval. We're going to spend the remaining time in this chapter talking about things which prolong the PR interval. When the PR interval gets beyond 200 milliseconds, or 5 small boxes, then an abnormality in conduction pattern is occurring. These abnormalities are called heart block. There are 4 forms of heart block which can occur. They are termed first degree, second degree type 1, second degree type 2, and third degree atrioventricular block or heart block. We will spend some time looking at each one of these abnormalities. Let's take a look at this first tracing. Unlike some of the ECGs we have looked at before, where the PR intervals were either normal or short, it should be easy to discern that this PR interval is too long. If we look at any of the complexes on this tracing and measure from the beginning of any of the P's to the beginning of any of the QRS's, we can see that this far exceeds 200 milliseconds, or 5 small boxes. This PR interval is approximately 250 milliseconds. This would be called sinus rhythm with first-degree AV block. First-degree AV block means that the PR interval is consistently longer than 200 milliseconds. It is important to make sure that each PR interval is consistent and long. Because of the decremental conduction properties of the AV node, a single PAC, in other words an atrial beat which occurs early, will also cause a prolongation of the PR interval, but it will only be on the beat during which the PAC is present. Let's take a look at a 12-lead ECG that demonstrates this phenomenon. Here you can see normal sinus rhythm with a normal PR interval. Over here is a PAC. The beat occurs early or prematurely. There is clearly a P wave in front of the QRS, and the P wave morphology is different from that of sinus rhythm. When the PAC occurs, you can see that the PR interval is longer for the PAC than it is for the sinus beat. All of the other PR intervals will return to their normal values. First degree heart block means that there is a slowing of conduction in the AV node that is present on each and every beat. This rhythm strip clearly demonstrates first degree AV block. The next form of heart block that we want to talk about is second degree heart block. Second degree heart block has 2 forms, type 1 and type 2. Both forms of second degree heart block mean that intermittently a P wave occurs without any conduction to the ventricles. The pattern of conduction which precedes this dropped QRS is what determines whether it is type 1 or type 2 second degree heart block. Let's look at some of the patterns of second degree heart block. First, here is a single lead tracing of normal sinus rhythm with a normal PR interval. There is 1 P for each QRS. There is no evidence for any type of heart block in this particular tracing. In this tracing, however, it should be apparent that there are P waves present without QRSs following behind. This occurs on both the 4th and 8th P waves. It is most important to first determine that the P wave which is not conducted is not simply a blocked PAC, or premature atrial contraction. For comparison, I'm going to place this strip underneath. This is a blocked PAC. You can see that the shape of the P wave is different from the sinus Ps, and in addition, the P to P interval has been violated. The first 3 P waves in this tracing are the same distance apart. This 4th P wave occurs early or prematurely. This is a blocked PAC and is nothing other than a manifestation of the decremental conduction properties of the AV node. This particular tracing is normal. When we compare that to the tracing above, we can see that the P waves occur on time. The P to P interval between the 1st and 2nd, 2nd and 3rd, and 3rd and 4th beats are all the same. Therefore, this is a form of second degree heart block. The question is, which form? If we look at the pattern of conduction, in other words, the pattern between the P wave and the QRS, we can see that the PR interval changes between the 1st, 2nd, and 3rd beats. The PR interval is normal on the 1st beat, it is longer on the 2nd, it is even longer on the 3rd, then we have the P without conduction. The pattern then repeats itself with the PR interval shortening back up on the 5th beat in. This type of conduction block has 3 correct names. It can be called Mobitz 1 AV block, Winky block, or second degree type 1 AV block. All 3 terms are acceptable. I'm going to get rid of the tracing with the blocked PAC and in its place put a third tracing. Again, we see that there are P waves present without QRSs. The fourth P wave in has occurred without conduction to the ventricles. We can see that the P to P interval is the same between the first and second, second and third and fourth beats. Therefore, this is not a blocked PAC. This represents some form of second-degree heart block. If we look at the PR pattern, the PR interval is fixed on the first, second, and third beats. Then suddenly a P wave occurs without conduction to the ventricles. This is called Mobitz 2, or second-degree type 2 AV block. Both terms are acceptably correct. The final form of atrioventricular block is manifested on this tracing. You can see that there are numerous P waves that are present without conduction to the ventricles. The P to P interval is regular, and the R to R interval is regular. However, the R to R interval is much slower than that of the P to P interval. This is typical and classic third-degree atrioventricular block. There is no relationship between the atria and the ventricles electrically. The atria are going at their own intrinsic rate, which is faster than the escape rate provided in the ventricles. In summary, the PR interval is the measurement of time from the beginning of the P wave to the beginning of the QRS. It includes the entire P wave and the entire PR segment. The normal value is from 120 to 200 milliseconds in duration. Abnormalities in the PR interval can manifest both with shortening of this interval as well as prolongation of this interval. The only causes of shortening of the PR interval are accelerated AV conduction, pacing, and WPW preexcitation. The causes of prolongation of the PR interval fall into the category of heart block. First-degree heart block is a persistent and prolonged PR interval greater than 200 milliseconds in length. Second-degree heart block has type 1 and type 2 forms. Type 1 form is also called Mobitz 1 or Winkie-Bach, and type 2 is also called Mobitz 2. Second-degree type 1 block manifests as a progressive lengthening of the PR interval followed by a dropped QRS, and the pattern repeats. Second-degree type 2 manifests without alteration in the conducted PR intervals but has sudden loss of conduction in one of the P waves. Third-degree heart block is manifested by no correlation between the atrial and ventricular rates. The atrial rate must be faster than the ventricular rate, but there is no relationship between these values.